Now, when it comes to ventilator management, pre-ECMO, if you remember the settings that I had shown you, this guy had a peak pressure of 40, have very high CO2 and a very low oxygen. So these patients, before going on ECMO, they are on lung non-protective ventilation because essentially we're just trying to keep them alive till we get the ECMO cannulae in. So once we put the ECMO cannulae in and we have established the patient on ECMO, we do what is called as lung rest. So ideally, we don't want to ventilate the lungs at all because any mechanical ventilation causes lung damage. But because we can't do that, so what we do is what is called as 10-10-10. So we set a pressure control of 10, PEEP of 10, and a respiratory rate of 10 per minute with minimal lung ventilation. With these settings, you will hardly get a tidal volume of 50. But that doesn't matter because all of your gas exchange is being done by the machine. We target saturations of 85 to 95%. And CO2, normally we say that ARDS management permissive hypercapnia is an accepted standard of care. But in a patient on ECMO, there's no reason to keep the patient having permissive hypercapnia, because the whole point of permissive hypercapnia is in a mechanically ventilated patient, higher CO2, the risk of having a higher CO2 is lesser than trying to overventilate the patient and causing ventilator-induced lung injury. So in a patient on ECMO, we don't do permissive hypercapnia because we can manage the CO2 using the sweep gas on the ECMO. Now, the other major thing about ECMO management is coagulation management. So basically, why do we need to anticoagulate these patients? So every time the blood comes into contact with the circuit, it causes platelet activation, complement activation, and endothelial activation, and leukocyte activation. So basically, it causes inflammation and it causes coagulation factor activation. So these patients are prothrombotic, right? So we need to treat that. And essentially, these are the two extremes of what happens. So either you have a prothrombotic patient where the filter completely clots out with blood clots in it, or you over anticoagulate the patient and the patient has an intracranial bleed. We don't want either of these two, and we have to achieve a balance between both of them. Now, normally we use unfractionated heparin because it has a very short half-life and we have a lot of experience with it. So initially, once you puncture the vessel and the guide wire goes in, you give a bolus of 50 to 100 units per kilo. And then you give a maintenance dose of 10 to 15 units per kilo per hour. So monitoring, normally we do what is called as ACT, or activate clotting time, because it can be done on the ward in the ECMO ward and its point of care. So normally while maintaining, we maintain between 180 and 220 seconds. We can also do a TEG, which is a viscoelastic thing. TEG gives you essentially not just heparin effect, but also if there are abnormalities, etc., but it is costly and all centers don't have it. APTT can be used, but again, it needs to go to the lab, come back. So it's very fast. And recently, there's been an increasing use of anti-10A levels, even for unfractionated heparin, because it is more specific. And studies have shown that it achieves faster anticoagulation targets, but it is expensive and it is not available in all the places. So the problem with heparin, and the most feared problem, is heparin-induced thrombocytopenia and thrombosis. So if we do diagnose this condition, then we have two alternatives: bivalirudin and argatropan, which can be used. And if the patient has a bleeding complication due to heparin, then you can even run an ECMO with no anticoagulation, permitted that you have adequate flows. So you need at least 3.5 to 4 liters of flows. In the newer circuits that we use, they are all heparin and albumin coated. So the incidence of clotting comes down, but you need adequate blood flow to make sure that there are no clots forming in the circuit. So from a machine point of view, we have to look at the membrane health all the time. So we need to look at whether the gas transfer is happening adequately or not. This is done by regular blood gases, pre and post membrane blood gases, to look at how the oxygen transfer is happening. And we've already talked about flow changes and pressure changes as the membrane clots off. There are changes to the flow, and then because the blood is coming into contact with an artificial membrane, sometimes you get hemolytic changes. So for that, you look at the free hemoglobin percentage in the patient's urine, fibrinogen content, and platelet content. In a worst case scenario, the membrane sets off what looks like a DIC pathway in these patients, requiring you to change the membrane or basically the circuit. The other important aspect of patient management is basically changes to pharmacology. So because you're putting a new circuit to the patient, it increases the volume of distribution of drugs. Also, because it's albumin and heparin coated, there's a lot of adsorption of drugs onto the circuit. So volume of distribution changes, and also the action of these pharmacological agents decreases. So all of these patients have a higher requirement of sedation. It is not uncommon for us to see patients on propofol plus midazolam plus fentanyl or morphine. But the most important part of it is that all the drugs, the antibiotic doses, need to be changed. Because if you're treating a patient for, let's say, bacterial pneumonia, ARDS, if you're not achieving adequate antimicrobial doses, you will never treat the patient, and it will cause even more resistance and increased duration on ECMO. So after day 7, this patient, you can see the lung opening up a bit. There is improving tidal volumes. So at this point, what we need to do is we need to start weaning the patient off, ventilate the lungs. So what we do is we increase the pressure control, increase the minute ventilation, see if we can ventilate the lungs, get some gas exchange going through the lungs, and decreasing the sedation, making sure the patient is breathing on their own.